Thank you, Carolina. And indeed, it's a pleasure to be here and participate in this wonderful meeting. What I'm going to focus on is the pre-symptomatic patient, or what we think is the pre-symptomatic patient. You're going to see some of the same slides from that have already been shown by earlier presenters, but I'm going to try to look at it from a different perspective. And I'm going to challenge you a little bit to say, is there really a pre-symptomatic patient? Okay, because this is really important. As you've heard from the other speakers, the emphasis is towards early treatment and with newborn screening, even before there are clear signs or symptoms of the disease. So with that, let's start. And I want to begin with the acknowledgement slide rather than at the end. This is the PNCR group that you've heard about, and with Dr. DeVivo has been our fearless leader the past 15 or 16 years, and it's now a 5-site group, and we've been collecting data over these 15 years. And that has resulted in, I think, a lot of important observations about SMA. But those are now almost historical. Things are changing. So you've heard about the trials. So we have a better definition of what is the natural history of SMA, and now we're learning that that's all changing with the treatments, and then now with newborn screening, yet there's another opportunity. So I want you to keep in mind that there are these different data sets, and it is a time of confusion. It's a good state to be in. Sometimes confusion is good, but and hearing from your questions, that's where we are. We're struggling with trying to find the right answers when it comes to an individual patient. I want to acknowledge also important funding from the SMA Foundation to our group, support from Cure SMA and from the NIH. And these are just my own personal disclosures, and I think Dr. DeVivo's are quite similar. So what do we mean by pre-symptomatic? Well, it should be self-evident that we mean there are no apparent clinical features of the disease at that point in time, at that particular age and stage of development for that patient. So you have to consider when you're looking at a particular patient, whether it's a newborn baby or perhaps an older child that presents who's been genetically identified as having SMA, do they have, first off, is the development of that child normal for that age? What about the examination? Is there the importance of, are the reflexes, if they're present or absent, is that relevant? What about the motor function testing that you've heard about, these different scales? And we're going to go into each of these. And what about strength? We didn't really talk about measuring strength because it's hard to do reliably in little children. But what about in older, if you get that patient with the type 3, type 4? What about strength and endurance? So you have to put together the full picture. So let's say there is a pre-symptomatic patient with SMA. Looks totally normal to everyone, to the therapist, to the pediatrician, to the neurologist. Is that child really having no evidence of disease? No. There is evidence of denervation if you look at these patients, and we're going to show you some information, some data that supports that there is a process involving denervation early on, but you don't see it yet. And that's because there's this process of sprouting and reinnervation, and there's been a compensation that begins in fetal life, and this was pointed out by some of the data presented by Dr. DeVivo, to show that very early on, in fact, there are signs of denervation. But there's the reinnervation and there's the compensation. So these babies appear normal, but in fact, they may have already lost substantial numbers of motor neurons. So I think it's important that we want to keep that in mind. The next point is that having these different biomarkers can be quite useful in trying to identify some of these subtle or perhaps even preclinical signs of denervation. And that might be an electrophysiologic measure, such as the compound motor action potential, the neurofilament level that you've heard about, and other ways of looking at things, maybe muscle mass that you can identify on a DEXA scan or other imaging modalities. So to me, the real challenge in SMA, whether it's pre-symptomatic or in the symptomatic patient, is how do we halt this denervation and the subsequent atrophy? So the denervation, as you've heard before, in the type 1 SMA begins in the fetus, and it's most pronounced in early infancy. And then the need for the SMN protein is certainly there throughout life, but it seems to be a little bit less as the child matures and goes into the adult years. So there is this compensation early on that obscures this phase of disease. So what I'm trying to say here is that pre-symptomatic does not mean that there is no pathology present. And the point also is that early treatment clearly provides the optimal opportunity to rescue these babies and these older children so that they respond most effectively to the treatment. And that leads to the next point as well, is a cure really possible? If these babies in their fetal development have already lost a fair number of motor neurons, what's going to happen later on? Even if they have a wonderful response to these drugs, what's going to happen when they're 10 or 20 or 50 years old? So there's still a lot of questions that need to be addressed and answered. And then the final point listed here is it really safe to wait to initiate treatment? So even if the baby looks totally well, and even if the genotype, let's say there are 4 or 5 copies pertinent to the prior questions are present, is it really safe? Because you know there's denervation going on in the background. So why would you want to wait? So those are all some of the points I think that will drive the rest of this discussion. Okay, so you've seen this before. I'm just going to show you the genotype-phenotype from a little different point of view. So if you have on the left-hand side here, 1, 2, 3, 4, or 5 or more copies, and on the right-hand side are the type, the clinical phenotype, type 0, 1, 2, 3, 4. Okay. Now, if you have 1 copy, it's highly predictive of type 0. And the arrows that I'm showing here, I've selected if it's a 98% or higher probability. Okay. So if you have 1 copy, you're almost certainly going to be a type 0, and if you have 5 copies or more, you're certainly going to be a type 4. But everything in between gets fuzzy. Now, in the yellow here is if you have 2 or 3 or 4 copies, you're most likely statistically to be a type 1 or 2 or type 3 respectively. But it doesn't always work that way, and that's what you heard from Dr. Shea and from the other speakers. So if you have 3 or 4 copies, you may actually have a type 1 or type 2. And if you have 2 or 3 copies, you may have a type 2 or type 3. Okay. So you need to keep this in mind, and I think this is particularly important when we talk about getting that genotype back on a newborn baby, and it gives you that copy number, and you say, how do I present this information to the parents? How do we move forward? How do we make a proper decision as to when to treat and who to treat and which treatment to select? Okay, so this is a video of one of the babies I've treated, and it's similar to what you've seen before. He's lying there in the frog leg posture, and clearly symptomatic. The belly breathing, the shallow breathing. He cannot even hold his head midline. Okay, so just to say, this is the typical baby, and this is the natural history. And the point I want to make about natural history is most of the data that you're seeing is not true natural history because it's indicative of our current supportive care. And just like what Dr. Parsons said, good supportive care changes everything. So the true natural history is shown here, and this is back data actually from the 1970s, 1980s largely. So this is survival pre-supportive care, before there were G-tubes, before there was BiPAP available. Okay, and you can see there was still about 20% of type 1 infants who lived long-term for 10, 15, 20 years. Now, these were not genotyped, so we don't exactly know if they all had SMA, but take that for what it is. Now, this little baby over here on the left, so he's now sitting and starting to weight bear, but he's 6 years old under treatment. So, and he's now talking, and he's starting to take some food again by mouth after having G-tube, and he's still needing BiPAP at night. Okay, so that's the symptomatic. What I want to turn now is to some of the same data you saw before, but let's look at it from a different point of view. So here's the CHOP intent, which is the infant motor scale we often use for type 1. And on the left is our PNCR study, and there were no patients that we identified these are all symptomatic, who had a score above 40. And similarly, the NeuroNEXT, which included only recently diagnosed patients. Our PNCR data on the left included both recently diagnosed and more chronic patients who were in our clinic. But the NeuroNEXT on the right were all recently diagnosed. And again, they had no patients who had a CHOP INTEND score of above 40. So does that mean if you're above 40, you're normal? Well, not exactly, but we're going to talk about that. What about the compound motor action potential, which is an electrophysiologic study? And this is work of Kathy Swoboda, which is really quite informative. And in black are all the symptomatic babies at their baseline visit. And you can see that they have very low numbers. Normal is somewhere up here, at least above 3 is felt to be the lower limit in normal for a typically developing baby. Okay? And I'm just going to blow up this little part on the left here to show these 3 white diamond figures, symbols, which represent the pre-symptomatic babies. And you can see that there's a big range, that there's no overlap with the symptomatic, but it's close. One is under 3, which would be lower than a typically developing baby. But look at the range in this response, and this is an electrophysiologic one. Okay. And then there was a case report I presented, which was a pre-symptomatic baby, and the CHOP INTEND score is in the white circles, and you can see how it quickly plummeted, excuse me, over the first 6 weeks of life, as well as, sorry, the decline in the compound motor action potential, how it quickly plummeted and stayed low to the point that the baby died here. At this point. And represented here are the 3 other pre-symptomatic patients from Dr. Swoboda's study showing the decline in the CMAP. Okay, so there's this early precipitous decline in both motor function and loss of neurons, to the theme that you've heard earlier. So let's go back now to the NeuroNEXT study. So represented here in the blue arrow is this CHOP INTEND at the 40 cutoff. And in this study, these are in the pink are the babies that had symptomatic SMA and 2 copies of the backup SMN2 gene, okay, shown here. So you can see that the mean score was about 20 with not a whole lot of, thank you so much, Julie, change or variability between the min and max in the range here, okay? So it was low and it never went up, it just kept going down over time. And then in the blue represents typically developing babies who did not have SMA. So you can see there's a clear spread, but at the bottom here is just barely above 40. So there is a gap here, okay? But so if you have a CHOP INTEND above 40, does that really mean that you're, quote, in the normal range? Okay. And what about with the CMAP? Well, there's virtually no overlap from this study group, but you can see the pink is the symptomatic SMA type 1, and this looks at the area under the curve for the CMAP, and in the blue represents the typically developing babies, and we're just going to focus on the red, which is the 2 copy. The black line represents 3 copy in the gray here. So you can see if you have 3 copies, it actually gets a little fuzzier because now the median is in the normal range. There's a decline over time. But what I'm trying to point out here is that it's the distinction between a symptomatic baby and a typically developing baby is not so different. There is a little overlap in some cases, particularly if you have 3 copies. Okay? So you've seen this slide about 5 times already. Okay, I'll just let it unfold. Okay, so this, the point I'm trying to make here is that this is the case for newborn screening, that early treatment, this is the pre-symptomatic nurture study, these babies do so much better on this motor scale than the symptomatic treated babies, and these are 2 different studies in the red and black. But notice that there is some difference between those with 2 copies in blue and those with 3 copies. And it looks like they're hitting a plateau, but in fact they've hit the ceiling effect on this scale. So we had to move them to a different motor function scale once they got up close to either 60 points on the chop intent, or here on the Heine part 2, once they got up to about 24 points. But I think this was a strong argument for promoting newborn screening when we saw that how these pre-symptomatic babies were doing. Okay, so here's one child. Now, these videos, again, are with the permission of the parents. I asked the child if I could use the video now that he's 4, and he said no. But, but I'm going with what the parents said. Okay. So here he is at 12 months of age, and he's doing what 12-month-old babies do. And we're trying to look at different things here. He's sitting, his fine motor. I'm looking at his pincer here. Okay, so these are how we're trying to capture these different particular items. And we'll talk more about this tomorrow when we go through the different scales. Okay, so, and here he is walking reluctantly. He's sort of saying, I don't really want to be in a clinical trial, but I have no choice. Okay, so he's walking, and so this is a little baby whose sibling died at 7 months of age of SMA type 1. This little guy was treated at 9 days of age with the nusinersen. And not only is he sitting, which means it's transformative, but he's walking, and he achieved walking at a normal age, at an age of a typically developing baby. Okay. And the little girl to the right, she has 3 copies, and she's ready to go to work, it looks like. She's doing quite well, and she's a sassy little thing. Okay. So I'm going to show just a few points from a paper that Dr. Vivo and the colleagues recently published on this nurture study. And again, and this shows that if you have this is survival. Okay, so you can see if you have, and free of ventilation, meaning you've needed no ventilation for more than 6 hours. So if you have 3 copies, you're doing just super swimmingly well. If you have 2 copies, which is in the blue, there have been a small number, somewhere around a quarter, who have needed some BiPAP support, either transiently, not necessarily permanently. So, and the black is the total group. So survival is great, but not totally normal. There's some subtle issues here that we're starting to identify. What about their motor milestones? Well, again, if you look at those with 2 copies, which is on the left here in the blue stars versus the 3 copies, you can see that all of the babies in this nurture study with 2 copies and 3 copies are sitting, but a few of them were a little bit late to do so. Walking alone, similar, and then on the right-hand panel represents when walking was achieved, and you can see the green dots represent the 3-copy babies, and they all achieved walking before this vertical line, which is considered the upper limit of normal for independent ambulation, okay, which is at 17.9 months. So, but you can see that about half of the 2-copy babies walked within the normal age range, and about half they achieved walking, which is spectacular, but a little bit late. And there are still 3 that they haven't yet achieved the independent walking here at a little bit later on. So what are we learning from this? We're learning that even early treatment, these were all babies treated under 6 months of age. They're doing spectacularly well, but not in all cases normal. So does that mean that denervation is starting to express itself even while they're being treated? So this is again showing the Heine 2 data and a slight difference between the 2 and 3-copy patients. So what are we learning from these studies? Now this is really important, as was pointed out earlier. This is the neurofilament, the phosphorylated neurofilament heavy biomarker. You can measure this in blood as well as spinal fluid. And so shown here in blue are the 2-copy babies. And the higher this is on this scale, and this is a logarithmic scale, the greater the degree of axonal denervation. That's largely what we're trying to reflect here in this particular biomarker. And you can see that the 2 copies are higher than the 3 copy patients, by and large. And the red triangles represent typically developing non-SMA infants. So you can see that the 3 copies are largely in about the same range as typically developing infants, okay? Whereas the 2 copies are clearly higher as a group, okay? And then this shows some response over time to treatment, that there is a response, but it doesn't come down to normal. So even as well as these babies are doing, you can see there's still a spread between the 2 and the 3 copy babies using this particular biomarker. Okay. So there are other pre-symptomatic studies. I just showed you data from the nusinersen-treated babies called the NURTURE study. Hoffman-LaRoche has something called the rainbow fish studies. You've heard about the fish studies. This is still recruiting. So if you are familiar with a baby who is identified under 6 weeks of age with 2 or 3 copies of SMN2, you may want to reflect upon this and see whether maybe the parents would be interested in going to one of the study sites, because this is still recruiting. Avexis has its pre-symptomatic study that recently completed enrollment just in the last month. And similar criteria, less than 6 weeks of age, normal exam, 2 or 3 copies of SMN2. Now, we don't really have any data on this yet, other than to say that the babies appear to be, doing really quite well. But to the point that was raised earlier, can we compare things? No, I don't. I think it's a little early to be able to say that one works better than the other. But in a few years, hopefully, we'll have that data. All right. So this is some of the early data coming from the SPRINT study, which is the pre-symptomatic Zolgensma gene replacement therapy. Okay. So the shaded gray here represents the symptomatic babies on the CHOP INTEND scale from the NeuroNEXT study. Okay, these were all recently diagnosed babies who were untreated. And shown here are the individual spaghetti plots of the babies at this particular interim analysis, showing how they were at baseline. And you can see that if remember a cutoff of 40, well, you can see that here, 2 of these babies were below 40 on the CHOP INTEND. And yet the investigator at that time felt that they were normal. So they were included on their exam, and they otherwise met the criteria for this study. So they were included, and you can see that they've responded quite nicely. Now, on this CHOP INTEND scale, 64 is the maximum point. So this is basically representing hitting the maximum, the ceiling effect, so it looks like a plateau, but they can't really do any better here. Okay, and you can see that of the babies who had a baseline above 40, and this shows you each little circle is a different baby and the age at which they were treated. And see, this is 1 month of age, so these babies here that I'm highlighting were all treated under a month of age, and you can see they've done swimmingly well also. Some of them almost at the maximum to begin with, but staying right up there. Okay, but again, sometimes it's what we learn is from the outliers. So I want to point your attention to some of these, like the ones below 40, and see, but are they truly pre-symptomatic? Going back to our earlier discussion. Okay. Now let's look at this same data using the Bailey 3 gross motor score. Okay. Again, same babies we showed before in the prior slide. And these are on the left, those that have 2 copies of SMN2, and on the right, 3 copies. And I think you can appreciate that they're all going up. None have plateaued, none have gone down. They're all doing really great, but you can see that they're not all quite in the gray zone, which is the normal for typically developing babies. Okay, from the Bailey, we have robust normative data. So you could look at these 2 and say, well, what do we learn from these couple babies, but compare it also to the babies who were treated who have 3 copies, and they're all staying very nicely within the normative range. Okay. Okay. So I want to turn to now some information that was presented at the World Muscle Society meeting in October in Copenhagen. And Linda Lowe's and her group at Nationwide Children's Hospital presented a very nice poster, and she kindly shared these slides with me. And Carolina mentioned this in her talk. So this is where you put a baby on a mat, and you put a camera over him, and that you put these little markers at the hands and the feet, and this camera picks up the extent of movement from each of these little limb monitors. So you could see this here in pink is going to be the right foot and the left foot, and this is the right arm and the left arm. Okay, so it collects this data, and you're just looking at spontaneous movements of the babies, and you're trying to get them in the right behavioral state, of course. Okay, so on the left-hand panel is a SMA type 1 baby who is felt to be pre-symptomatic at 26 days of age, who had a CHOP INTEND score of 50 points, which is above 40 and very, very good. And you can see the movement patterns here of right arm, right leg, left leg, and compare it to the control baby, 21 days of age, with a CHOP INTEND score of 53 points, so pretty well matched. Okay, and you can see much more activity of the limbs, which is shown graphically on the right over here. So here's the SMA baby, okay, and this is the number of meters of activity. So each of these, this little pink line over time shows how many meters of activity was picked up over this time point from this one sensor. In this case, this was the left foot, okay? But you can see how different it is. Just focus on the pink if you wish. So the left foot of this baby, and look at the difference here from the typically developing. Okay, so it's not a huge difference. You have to look at the scales carefully, because here's 0.8, but 0.8 would be down here. But I think, and it's one patient compared to one other patient. But I think this is really quite instructive and interesting. And if you look at this graphically a little bit differently, if you take this baby, and these are the 3 different SMA babies, and it looks at, in X is their baseline, and how they respond over time. Yeah, they go up very nicely in response to treatment, in this case with Zolgensma. But compare it to the 3 controls who, are up here and, well above. So some of them, this baby in the middle panel, you can see how it goes up and seems to be capturing similar activity to the controls. But that's not true necessarily of all the babies. So while they're doing really remarkably well, no doubt and no argument there, I think these are interesting observations that I wanted to share with you. Okay, so let's look at this a little differently. So here's the control group, and this is based on a 100-point scale, 0 to 100. And the untreated SMA babies, here's the paucity of movement that they show, way down here in the orange. Something like 3% of what you see in a typically developing baby. The treated SMA patients, meaning they were symptomatic and treated, they do show a response. And here's the pre-symptomatic, okay, SMA. So, but this is also at baseline. So you can see that, there's a pretty marked difference here in some regards. Now, if you look at the 2 copy versus the 3 and 4 copy, and symptomatic. So let's look at this. The little gray dots at the bottom represent symptomatic type 1 babies with 2 copies of SMN2. That's going to be your typical Verdnick-Hoffman type 1 baby. And you can see they're low to begin with, and they just stay low on this cross-sectional study. And then you can see where those with who are pre-symptomatic with 2 copies, they're clearly higher, but they're certainly not in the pre-symptomatic zone up here. Okay, and then they just had a single baby with 3 copies and one with 4 copies. So we need much more data, but I thought this was really quite interesting, and I wanted to share that with you. So I want to conclude with being a little provocative again to say, is there really a pre-symptomatic state? Okay. Or are they more what we would call post-symptomatic? There's subtle features there. We have to look at them carefully. We need you as the physical therapists to sort of tease this out, because we're having to learn something new here. We didn't see these babies before, but with newborn screening, they're going to start coming in more regularly. And you'll hear that there's maybe 6 or 8 patients in Colorado and 50 or 60 patients in California, and in my state, in Florida, we're expecting about 20 per year. So we really need to be prepared to evaluate these babies very carefully. I'm not so sure that what we're calling pre-symptomatic is truly normal. And it may mean that we need to look at biomarkers, but we clearly need to look at them very carefully at a clinical level. To make the point again, we'll go back. Early treatment clearly makes a difference. I'm not arguing that. And certainly pre-symptomatic or early after birth, whatever we're going to call it, that is our best opportunity to get the most robust response to whichever of these 3 treatments we're discussing today. And again, there's the need for maybe even more sophisticated clinical and biomarker measures. Maybe we need to be doing more here. And then, as I said, with the advent of newborn screening coming, there are going to be these 2 populations of patients, the symptomatic patients who are in the clinic now, and they will still trickle in because the newborn screening is not going to pick up everyone, as you heard. But the bulk of them are going to be picked up in this early postnatal life. And it's going to be up to us to try to better learn from them and try to identify the path forward. So with that, I'm going to stop. I think we have some time for some questions. Thank you for your attention.
You really touched on some of the critical questions. And certainly I loved you talking about the pre-symptomatic issues. And maybe we should substitute another term as you're suggesting. I was thinking, accumulating disease burden that may be unidentifiable clinically at the early part and increasingly identifiable clinically at the later part. And this is probably relevant to so many genetic diseases that we deal with. Yeah.
I agree.
So we'll open it for some questions. We have 1 or 2 questions here. Let's see if I know how to do this. One of these, Richard, it says, I guess the flip side of are there pre-symptomatic patients will be, are patients cured if effectively treated pre-symptomatically, which is a nice twist on that.
Right. So what is a cure? Is it normal development? Is it normal health, good quality of life, which we haven't talked yet about, but clearly that's important. Patient-reported outcomes, caregiver burden, quality of life. To be able to live life without limitation or restriction or pain or suffering. Does it really matter what the neurologist finds on the exam? If we don't find the reflexes, do we really care about that? Well, it's telling us something. Yes, of course, it's important. But is it really important to the patient? So I don't know exactly how to answer that. I think we're concerned that some of these treatments, even when initiated pre-symptomatically or early in life, postnatally, that eventually some of this early denervation is going to catch up and show itself. So whether, again, that's at 20 or 30 or 40 years of age, are we going to see what we call the post-polio syndrome type situation? These are the babies that or children that had polio. They recovered, they got back to walking, they were functioning well, but they had a reduced number of motor neurons because of their polio. They lost a substantial number, 50%, 80%, but those surviving motor neurons were able to sprout and reinnervate and carry them along for several years, but eventually they start to age, as unfortunately we all do, and that catches up with you because they have a reduced number of motor neurons at that certain point, and they start to fall off the cliff and become symptomatic. So we are concerned that that may happen later on. And then, of course, in growing children, which is what we're largely talking about here, we need to sustain the growth of the child. So you heard from Dr. Parsons the issues that sometimes we see problems around the time of puberty and the growth spurt at that point. So are these treatments really going to be able to sustain these babies through the different phases of growth and development? I think that still remains to be seen.
All right, we have several other questions. There's one here, I guess, from 3 people. It's not the SMN1, but I think they mean SMN2 copy number. But how much SMN is expressed? If so, how much SMN expression is needed for normal motor unit development? Is there a better experimental measure of this than SMN copy number?
Okay, well, I'll start and then you can give the correct answer. I think that's a very important question because you're right, it's not the SMN2 copy number because we know that not all SMN2 copies are equivalent. There are variations in them and there are gene modifiers and there's other things we haven't talked about today. But it's really how much SMN protein is generated by those backup SMN2 genes that is really what we're talking about. So it's how much of the protein and when does it get expressed and how much can it rescue the motor neuron.
I always agree with you. I would say
if only.
Part of the answer is that this is an autosomal recessive disease. So the carriers, who presumably have about 50%, knowing that like everything in biology, it's a Gaussian distribution, so 50% plus or minus 10 or so 40 to 60 maybe percent. But 50% the carriers generally are not affected during their lifetime, so something around 50%. And,
right, and they've had that 50% since they were a fetus. So what hasn't been quite addressed yet in this workshop is, should we be thinking about treating the fetus? Because there was a question that came up about, well, what if we identify a fetus? Yes, I'm looking at you, the genetics people here. So suppose there's a drug we could safely give the mother, and that's a big if, and it could cross into the fetus effectively. Should we be thinking that way? Should we think that we need to start rescuing motor neurons in the fetus? Because we know there is loss of motor neurons in the fetus, at least in the animal models, that's quite clear. And we know that there is this type 1 or type 0 SMA, rather, where sometimes the babies are born with horrible contractures and virtually no movement. So we're starting to be a little forward-thinking and trying to consider these other opportunities.
And I would add, at Columbia, we have a geneticist with our perinatal group, Dr. Ron Wapner, who has now just organized a study group for fetal SMN treatment. And they are talking about just the point you raised. That is, you can give something like, say, risdiplam into the amniotic fluid. It'd be swallowed by the baby, and that would be one possibility. They're very adroit at going into a vessel and administering something intravenously in the 3rd trimester. And Dr. Wapner is so confident, he said, we're even willing to do spinal taps on the fetus in the 3rd trimester. So there is that opportunity emerging to get in as early as possible as such. Are there any other questions from the audience? Richard, I can't resist asking you your opinion about 4 copies.
So As with so many Dr. DeVivo was one of my teachers in medical school, so you have to understand. There's a history here. And Dr. DeVivo can be persuasive. Let me share that. So, but he and Dr. Darryl, I think, have been quite persuasive in saying 4-copy patients really are part of the continuum. These patients are denervating. Do we really want to wait until they become symptomatic? And how good are we at really, if we were to wait and observe, how good are we at catching them at that very first point when they start to show any symptoms? And then at that point, obviously, you can't go back. You cannot turn the clock back and reclaim those motor neurons that you've lost. So why then would you even think about waiting, if I am paraphrasing you? And I think that argument has been loud and clear, and that's why the algorithm is largely being changed to say we do think that patients with 4 copies should be treated. The reason that there was some hesitation when that was published about 1.5 years ago was there was only one drug that was approved at that point, and that was the nusinersen. And that paper was put out to try to promote newborn screening. So it had a very particular focus on that. Now that there are 2 and hopefully 3 drugs where you're not talking about doing repeated lumbar punctures in a newborn baby who might be likely pre-symptomatic or post-symptomatic, and you have these other treatment options, it really does change everything. And I think also we have an extra 1.5 years of data on the Nurture study now that's been published to say, okay, if this is what we know from babies with 2 or 3 copies, I think you can readily extrapolate in some cases to say 4 copies makes sense as well. Yeah.
Do you want your child to lose 50% motor
Right. So to Dr. Yeah.
For that to happen?
So let me repeat Dr. Darris's point because it's an important one. So by the time the child's symptomatic, it's not that you've lost 5% of your motor neurons. It's a substantial number. It's felt to be 30, 50% probably. So why would you even conceptually think that that's wise to wait that long until they're symptomatic? Similar to metabolic diseases, similar to other things that are picked up on newborn screening. Why would you wait with PKU? Why would you wait with hypothyroidism to start the treatment? It doesn't make sense.
And Richard, I would add, and appreciate your comment, in the Nurture study, which I think was well designed and really is the harbinger to newborn screening, the CMAP value was greater than 1 millivolt, which from your data very clearly is abnormally low, yes?
Yes, I think that's an important point. That was the data we had at the time. And I think this study was well designed. But if you go back and you were to do a sub-analysis and look at the babies who had lower CMAPs, which is this electrophysiologic measure, and looked at the ones that had CMAPs between, say, 1 and 3, and compare it to others, you might find some interesting results. John, did you want to comment there?
Well, I was going to comment on something else, and that was more regarding the technical ability to distinguish 3, 4, and 5 copies. We're making this out as though it's a clear distinction, and I think it bears pointing out that might not be the case.
Right. The higher the copy number, the harder it is to reliably distinguish between X and Y. So it's easy with the current techniques, whether it be the qPCR or the MLPA, to distinguish between 1 and 2 and 3. Between 3 and 4, it's a little challenging, and some of the labs will only report 3 or more copies. And then if you say, well, I really need to know, is it 3 versus 4? Or is it 4 versus 5? That's when it gets tricky. And none of the commercial labs are currently, at least when I checked with them about 2 months ago, they were not saying that they were able to say whether it's 4 versus 5. So with that, our time is up, and I'm keeping you from lunch, but thank you. Okay.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.